Hello and welcome back to part 3 of my Implementing for Impact series. In part 1, we talked about how implementation is a complex problem. In part 2, we looked at how implementation science frameworks might help us. I introduced a model of implementation that might be really useful for you. And today, I promised that in part 3, I would actually take you through a real-life example of how I've used that model to guide how we did implementation, how we evaluated implementation. So that's what I'm going to show you today. My name is Dr. Christian Hudson. I'm an implementation specialist. I'm part of the Yorkshire Humber Applied Research Collaboration in the UK. I'm also part of the Improvement Academy, and that's based at the Bradford Institute for Health Research in Bradford, Yorkshire. Okay, so welcome to part 3 of the Implementing for Impact series. So key aims today. I'll take you through an example using the implementation model from the last video. And then, and while I do this, we're going to look at the engagement process, the method of implementation, and the evaluation process. So this is the intervention. You may have a different intervention. This is just to give you an idea, but I think you can still apply it to the same model. So that's the idea. So it was known as the Unscheduled Care Coordination Hub. What is that? Well, it's really looking at how the pathways that a patient will go through before they end up in hospital and get the help they need. And the normal pathway is a patient's, if there's an issue and they have a problem, that they'll be referred to 999. 999 will send an ambulance that'll transport them to hospital. What is the idea of an unscheduled care coordination hub? Well, instead of going to 999, the patient's referred to this hub, unscheduled care coordination hub, and then they actually find viable alternatives for them to attend hospital. Now, the reason for that is to try to decrease the pressures on A&E and on ambulances. You've probably seen on the news, there are these big queues of ambulances outside some of the hospitals, and you probably heard about people waiting, up to 12 hours or more to be seen in an A&E department. So this is a problem. So the idea is that for some people, rather than them needing to go to hospital, they may be able to get treated out at their home, out in the community. There may be viable alternatives. We can send out a district nurse to them, or maybe we can send them to their GP. But whatever it is, it's getting them what they need in a more efficient way and taking the pressure off the hospitals. Now, so within these hubs, there'll be, it's really just a group of people in a room of very skilled professionals. There'll be a doctor, social care worker, physio, district nurse, and they have access to the 999 call stack. So all the calls that come in, they can see. Now they have real-time visibility of that. They can interact with referrers on scene, and they have the ability to review patients' past medical and social care history in real time. So they may have somebody that's been calling 999 a lot, and they can see, and they can say, oh, actually, this person can be treated by the district nurse. Let's send her out. She knows her quite well. So it's that kind of thing of trying to take the pressure off. And the people that can refer into the hub is many, but it can be care home staff, nursing team, GP, ambulance. And for them, accessing community service providers is often very timely and complex. Whereas the care hub has got all these relationships set up already and links in, so they can do it efficiently. And so the outcomes really, ideally, it's aiming to get better patient outcomes, because if somebody's calling 999, it can take quite a long time for an ambulance to come, for them to get into hospital and then actually get what they need. Whereas if the care hub, in theory, can get the more appropriate care more quickly. Also better interoperability between services, because now we've got this hub that's actually can act as a central point for all the services in a healthcare system, to actually be communicating more efficiently. And then, of course, the big one is to reduce or avoid ambulance responses and ambulance conveyance rates, trying to take the pressure off them and free up ambulances for the people that have really acute injuries that really need it, and that can't be treated out in the community. So that's the intervention. Let's start applying this to our model. So the first part of the model is the what. Well, we know that's the Unscheduled Care Coordination Hub. So we now have our intervention, our change process, whatever that, we've got it. And so now the where, well, in this case, it was just one ICB. That's an integrated care board. There are lots of these boards across the UK, and they're responsible for health services and healthcare within specific geographical areas. So we had one ICB that was doing this, the who, and there's also the method in the model, and they're within system learning. So we know the where and the what. We've got that now down in our model, but we still need to know who are we engaging. Also, who's going to be doing the engaging? That comes in here as well. And a method. How are we going to do the implementation? Maybe it's the people in the ICB or who will be doing the implementation that come up with this. Maybe we help them. We still needed a way to capture this within system learning. Let's keep going. Now, implementation frameworks. Remember, we spoke in the last video, how useful might these be? Can definitely help us frame things. So when we're looking at our model here, we want to understand our context more, or we want to think about methods, or we want to think about engagement, or even when we think about how we're going to capture the learning in this, evaluate this, a framework or two might help. So if we're using CIFA, that will be about really going in and asking people about barriers, facilitators, asking questions around that. If it was the Paris framework, which we talked about, again, looking at the context, but also wondering about facilitation maybe. So they can be useful. They can help us design data collection, analysis, the evaluation, help us capture learning. But I think I also touched on that they have limitations, right? They can be very complicated for a start, difficult for people to learn. I also think it's difficult to use frameworks to really capture this within system learning. They're good up to a point, but frameworks won't actually do the implementation for us, and they won't do the engaging for us. Remember how important engaging is to get all this to work. So we have to understand their limitations, and I'm going to go into that a little bit more. But ultimately, our approach, I suppose, to unscheduled care coordination hubs was engage. So remember that I haven't included it here, but this model, the engage thing is absolutely vital. It's what fuels this model. Facilitate and evaluate. And I'll show you how we did that. So let's look at the who, right? The who, because we know the what, we know where we're doing this now. The who to start with, who's doing the engaging, who's doing the actual helping the implementation, who's evaluating. I'll show you. So we were very lucky in this project. We had an improvement specialist. Now, this person had practical experience of improvement processes, engagement, and unscheduled care coordination hubs. So he understood the context very well. He'd worked as a paramedic. He also had developed and designed this intervention, so he knew it inside out. He'd facilitated tests of change. Now, that's our method. I'm going to go through that in detail in a minute. He had a method for implementation, and it's based on this idea of rapid improvement. This comes from improvement processes, which comes from improvement science. Again, I'll touch on that in a little bit as well. And he knew who he wanted to talk to. So you can see we're already very strong in all these levels. Somebody who knows the intervention, somebody who knows the context, somebody who knows who to involve, and who has a method of implementation, a way to facilitate and support implementation. Now, who did the within system learning? Who captured this? The truth is, anybody involved in implementation, you'll know they're usually quite good at it, very good at it, but they're so busy doing it, right? This person's so busy engaging people, working with them, they don't have time to actually pick up how all these things are interacting and do a thorough kind of evaluation. So if you're a research team, you'll probably be particularly interested in this aspect of this video. And that's what I did with my research fellow. So we had experience of evaluating implementation. We had experience of implementation science frameworks and implementation science. And we had a way of capturing within system learning, an innovative approach, which again, I'll show you in this video. But we contacted the people involved in the implementation every couple of weeks. We used lightning reports, which is a rapid qualitative analysis technique. I'll show you that in a minute. We did baseline interviews. This is a more traditional approach to evaluating implementation. And we used a framework. We used the CIFA framework, the Consolidated Framework for Implementation Research. And so the basic engagement involved engaging ICB high-level staff, then engaging leads. These are the people in charge of services, managers, and then engaging the frontline staff. And the method was what we call a test of change. Now, I will go into detail. Let's look at that. So we'll start with the engagement process. What really was this like? We'll look at the method, test of change, and then we'll look at the evaluation, which is the within system learning. This is how this is all worked out. And as I'm doing this, just be aware that the limitations that frameworks have, they don't always tell you all this, right? So the engagement process, the first step was engaging the ICB. Now, our implementation specialist actually spent a while driving around the country, approaching ICBs, explaining the intervention to them and seeing if they'd be interested. So that already is a lot of work of engagement, finding a receptive site, a site that's ready, right? I talk about readiness in another video. That's motivation, capacity. Are they ready for this? And you're starting at the higher level because these are the people that decide whether things happen or not. So he would have to sell this idea of unscheduled care coordination hub. He would have to explain why it works, have to give previous examples. It's a storytelling process. This is just part of implementation. You have to sell things to people. We can't just expect people to take things up because they're good or they're in a paper by diffusion. There is a process of engagement. It's very important. Now, what you'll find when you're talking to higher level people, like people in the exec level, you will see that they'll say, well, look, if it's worked in one previous places, can you just give us the full business case from that place and we'll just use that? Because there's still this kind of mentality that if something's worked somewhere else, you just have to copy it and it'll work in your setting. But if you watch video 1, you'll know just as well as I do that implementation is a complex problem. Every system is different. And that means if something works in one setting, it won't necessarily have the same results in another. So we didn't say to them, yes, here's the business case, here's the examples from before. We said, no, for this intervention to work, we need you to build your own business case. So you need to, and we'll show you a way to do that. You do it through a test of change, build up your own evidence. So we offered to support them through a test of change that would give them their own local data to help them build a compelling case why they should implement this. So that's a key difference. So we've done the first stage. Now it's engaging leads. So we're at the second point here. Now, these are the people involved, people that are owning the shop floor, owning the services. They're responsible for overseeing that. So that was the next people we engaged. And the improvement specialist would go through a detailed Q&A session with them. It's two-way street, very detailed, asking them lots of questions. They would ask him lots of questions about the intervention. It's really making sure everybody understands how this thing works and what it's supposed to do and how could we make this work together. Things like, where do people sit in the building? What IT systems might we use? What will you need to make this happen? So really looking at the key principles of this intervention and trying to make it work for this context. And the third step was then really going into a planning session. How can we do a test of change? We've got a method for you. How can we think this will help you implement it? How can this happen? Come up with a shopping list to do the test of change. What do you need? Identify capacity, identify the skill mix needed, other resources such as IT, physical location. You'd be amazed. Actually, in this project, they had to keep moving because they didn't have a physical location in the end. They kept every week, they'd have to move everything into a new office, a new place. So it's another example, complexity. Settings are constrained, so that is engaging leads. And then, of course, we've now got the last point, engaging frontline staff. Very important. You'd be amazed how often this doesn't happen. And it was very nice to see an example of this happening. So the specialist, after telling the ICB, you're going to have to develop your own business case. After going through leads, look, we'll do this via a test of change. I'll explain that in detail in a minute if that's confusing. But we'll do this through a test of change. What do you need for that? And then frontline staff. Okay, go and meet them. Test out the technology. Make sure the wall plugs, the plug sockets where they're going to do this are actually on. You'd be amazed when you're about to start an improvement process, an implementation project. They don't even have the power in the building or something like that. So you really want to make sure everything's set up for this. And in this case, it was a test of change. Make up a number of sample patients, put them through the intervention. They wanted to test this out, check if they have the staff. Can't do a test of change if you don't have the staff, right? Once they have the staffing, the technology in place can then do, in this case, they did a week-long test of change. It was 5 days. So I keep going on about test of change. Let's get on to that, the method, right? Now, look, research teams, program teams might not have a predetermined method before you go and do implementation. It might be left to the context, the settings you're working in within that context to come up with their own approach. Fine. But in this case, we had a tried and tested approach to implementation. Now, what is test of change? Well, they stem from the idea of rapid improvement, right? Which stems from improvement science. It's an improvement practice. Now, the PDSA cycle you may have heard of, this is a very commonly used improvement approach. And it's kind of like saying, look, make a plan of how you're going to do the thing you want to do. So set goals, predict what's going to happen, plan data collections. You want to be collecting data on how it's going, do it, right? Then study what happened and then act, decide if you're going to keep doing it or try something else, and decide what your next cycle is going to be. So these are experimental and iterative cycles in nature, in reality, right? And now Trisha Greenhouse says, look, why don't we call them rascals? And I think she's right, because really what they should be called rapid and small scale change assessment loops. That's what these are. And of course, it depends on the situation, whether people can do. So these will form improvement cycles, right? Which I've mentioned before. So not everywhere's going to have the time or capacity to do improvement cycles, unfortunately. But I think they're an excellent way to deal with complexity and an excellent method to implementation, right? As problems arise, you can do PDSA cycles to find solutions very quickly and keep doing those, right? To keep optimizing your intervention, overcoming contextual barriers as they arise. Conducting small-scale tests through a plan that you study ACT cycle provides a useful and safe opportunity to try the idea, reflect on the outcome, and then either change the plan or try it on a larger cohort of patients. This is where it comes from. So what is a test of change? Well, it's really, a test of change will have probably lots of PDSA cycles in it, but it's really a way of saying, look, let's not just try and implement something permanently or for a year or 2 years. Let's just do a very little test of this change. In this case, we did 5 days. So when the improvement specialist approached the ICB, they said, look, let's just try out the unscheduled care coordination hub for 5 days. And of course, when you're doing that, it's a lot easier to get buy-in and plan for it. It seems less risky. The ICB, the managers, the shop floor don't have to prepare for something for like a year and get all the resources for that. Just do a test and see if it makes a difference. If it doesn't, we can forget about it and try something else. So you can see what happens, learn something. You can start to build your own business case. You know, the improvement specialist was telling me that he's done tests of change that are 2 hours, not even 5 days, because that's how limited the capacity was in a certain area, you know, or how much nervousness there was about changing something. So you can even do it for just 2 hours. So you're really just giving them something small, appealing, that's engaging, doesn't cost them anything, and they gradually get into it. It's safe, it's baby steps, less commitment, less fear. So again, it's all part of the engagement. It's all part of the method. It's all part of our model, that we're strengthening those domains up so we can get the best results possible, get impact, right? That's what we're really doing this for. So, yeah, so we've got a very strong method now. Yeah, we've engaged these people. We know where we're doing this. We understand the context. We've got a really good understanding of the intervention. So do all the people who are doing it. So what's left? Well, it's how do we capture the within system learning? How do we monitor what's going on? As I said, everyone doing these tests of change aren't going to have time to also be collecting data on how it's going and talking to people and keeping track of that. That's where my team came in, you know, with our expertise around evaluation. So let's look at that. Let's look at how we capture within system learning. This will be very useful for anybody who's been tasked with evaluating implementation, for research teams who want to know how to maybe research it, right? So as I keep saying, it's all very complex. And what we find, actually, if you look at a lot of implementation evaluations up until now, go and look at the literature, you'll see they miss often the ongoing interaction between these components, between context, between the intervention, between the people doing the implementation, between the method of implementation. Within system learning isn't picked up. There's a lot of reasons for this. I could do a whole nother video on this, but it's just the way that there is that science to service gap, that gap between science and practice. And a lot of our academic approaches to evaluation aren't actually very good at capturing this complexity. And the impact of that means that we often don't really learn how to implement. And this is what I've been very interested in, because then we can't really be sure how to have impact. So what a lot of evaluations do is just analyze the problem. If you look at my interview with Johan Fazy, the climate change professor we had on the podcast, he's saying that, you know, a very high percentage, 98+% of papers on climate change just talk about the problem of climate change, and only a fraction of them talk about implementing solutions to climate change. So that's just lots of problem analysis. It's the same with implementation evaluations. They're just analyzing the problem of implementation. I'll show you how. Look, they'll often, you know, something's taking place over 1, 2, 3 years, and our evaluations will have a defined set of outcomes. So we'll be looking, okay, the intervention outcomes, implementation outcomes, and something about the context. So people will often use generalizable academic implementation outcomes. So was it implemented or not? How did the implementation go? And they'll record things like, was it acceptable to people? How far was it adopted? Was it appropriate? What was the cost of implementation? But that doesn't tell us how to implement. That's just telling us something that's, well, these basic things. There'll be something about the context. So they'll use maybe a framework like the CIFA framework here. And so we'll know a bit about barriers and facilitators. So we know if the intervention was effective or not. We know if it didn't get implemented, and we'll know something about the context. But I think the problem with that, it can miss the complexity, and there are limitations. It doesn't help people in the future, because knowing it was feasible, knowing it was acceptable in one place, knowing that what the barriers were in one place, doesn't tell them about how to implement in their context now, in this present moment. So there are limitations to how evaluations are done. So we were really keen to capture that within system learning. We knew we needed a more innovative approach, and that's what we developed. And so the way we saw it was, okay, we have unscheduled care coordination hubs. We have certain outcomes we want to record, but let's see this as an ongoing process of learning throughout and try to capture the interaction of all these things. So how is test of change interact? Like how good is the test of change as a method of implementation? What's happening in the context as a result of this? How far are people achieving the intervention? What do they think about it? How is all this going on? And try to capture, as these people try to achieve this goal in this context, using this method, what happens? We need to capture that. And we need to capture it constantly, consistently throughout the process. That's why we made sure we followed these sort of 3 rules, really. We made it rapid, we made it relevant, we made it responsive. So it's rapid that we're now collecting data very, very regularly. So we know in the first week, in the first 2 weeks, how the implementation is going, how the test of change is going. We know straight away. And that's a lot more useful in the sense that now we can also be responsive. We can act on what we're finding. And when you take this sort of approach and you're talking to people more regularly and you're really taking into account these different domains, it's more relevant for people in the future, as I was saying, because you're going to capture that more practical implementation knowledge, the how-to. How do you do implementation? How do you implement this in practice? Now, you might say, well, how do you collect data so often? Isn't that loads of data? Well, we use rapid qualitative analysis. This is a great technique for actually capturing complexity and for making sure your evaluation is rapid, relevant, and responsive. What are lightning reports? Because that's the rapid qualitative analysis approach we use. We use these tools called lightning reports. Katie Brown-Johnson, the lead author here, she's a fantastic researcher. I've had a few chats with her about lightning reports. I'm very grateful for developing these and for sending over some resources. The key thing about these is they have 3 sections to them, basically: plus, delta, and insight. Plus is what works, delta is what needs to be changed, and insights are any participant or evaluator insights, ideas, and recommendations. So now you can also use something like implementation science framework, like the CIFA framework, to your lightning reports at the end of the project. So you can still use your more detailed frameworks if that's the way you want to go. But lightning reports are a simple, pragmatic way to get what you need in the moment. And I actually think anyone could use these, which is why if you're a PhD student or you're somebody on the shop floor about to do an implementation project, but you're overwhelmed by all the implementation science frameworks and you don't have time to learn them, lightning reports could be a solution. What do they look like? Well, here's a little template. Simple, 3 sections, right? What's going well? What needs to be changed? Any key insights? So in your intervention, or in the case of ours, the Unscheduled Care Coordination Hub, what we were able to do is visit the site that was implementing this, where the hub was being implemented, and just fill these reports out. So you want to talk to as many people as you can and just ask them what's going well, what's not going so well, and then you write your insights and theirs in here. So you can member check then. So once we'd filled these out, we'd send them back to the people involved in the implementation. And just to get their feedback, which validates the data, but it gets them more engaged because you're asking them to critique it. Very important to get this right. Once you've spoken to people, it might take you an afternoon. You can do it on Zoom. You might go in person. Might be phone calls. You then want to summarize, and that can take half a day sometimes. And then this bit can take a while because you really got to decide what are the key things to put in here. But a lot of exec levels won't have time to read the whole report. Bearing in mind, though, the report, we keep it to 1 or 2 pages. It's intentionally created to look nice, and you want it to be nice, short, and concise. This is what one looks like, not including one from our project here because we're still analyzing. We haven't published anything yet. But this is a lightning report from Primary Care 2.0, which was another intervention that Katie Brown-Johnson kindly sent through as an example. And you can see, that they're keeping here what's going well, what's difficult, and these key insights. And of course, this can then be fed back to the team or teams involved in implementation to use as they wish. But they now have an ongoing record of what's going on, and we have an evaluation. And so they really appreciate that. As I say, they're often just too busy to kind of keep this kind of detail of how the implementation going, how the intervention's going. They just don't have time. They're too busy doing the implementation. That's where, having an evaluation team is really useful. You can decide to maybe act on some of these insights or correct some of these issues or build on some of these positives. So that can facilitate information. implementation. And I think lightning reports, as I say, you could use this in the future. So it's very important that we have transportable findings, right? So, you don't want to work out how to implement something if it can't be then transported and used in other sites. Obviously, they'd have to tweak and, make it work for them. But I think lightning reports are a tool that could be used anywhere to support implementation. So it's more rapid. You know what's going on straight away. Yeah, in the first week, first 2 weeks, quickly. It's more relevant to people in the future because this is really capturing some of that practical implementation knowledge. And it's responsive in that the people doing the implementation can use this to guide them and respond to issues right now. So just to conclude, we've spoken about in the first video how implementation is a complex problem. So we need to approach it a certain way. I've given you this model as a way to kind of picture that, right? It's complex because the contexts are all different capacity, time, resources, relationships, etc. But it's also complex because all these are interacting. You've got your intervention, you've got your people doing it, and you've got a method of implementation. And you need to try and capture what's going on. So hopefully this model's useful to you. And now I've given you an example of where we've actually used this and in detail, how we've engaged, how we've made sure everyone knew what this was, how we've gone into the context, and actually giving an example of an implementation method, which was test of change. So just to conclude, implementation is very complex, unpredictable. So we need a method, we need an approach that can deal with that, right? This is one model. There's many others. You'll probably have your own over time, but don't forget, always pressure test your approach. Any model should be continually pressure tested. That's why we're running this kind of approach. We're running our our innovative approach to evaluation through lots of projects at the moment to see if it can handle the pressure of implementation in practice. And so far, it's working quite well. I'll probably make future videos on that to tell you how that's going, but always pressure test. Yeah, it does seem to work quite well. Certainly, if you are strong in these domains, like we were in the case of Unscheduled Care Coordination Hub, implementation is likely to go pretty well, particularly if you've had that engagement going on as well. That's absolutely vital. And our evaluation is pretty useful. So yeah, just to finish, relationships. I still think probably the most important thing, often overlooked, often left out. But you saw in the case of unscheduled coordination how much effort went into making sure everyone understood what this was. The person doing that understood the context. They knew who to approach. They approached everyone at every level, not just one of the levels. Didn't just speak to managers or get permission from the top or just agree with people on the shop floor. They really got everyone on board and they had an approach. So yes, relationships. There we go. So just to finish, this should be an approach that works for everyone. So whenever you're engaging, it's got to work. So, I said we contacted them every 2 weeks to do lightning reports. Well, it may be the people in the context you're working in, it's better to contact them every 6 weeks or every month. So just like we're expecting them to adapt to problems around implementation and steer the ship and adapt what they're doing to overcome problems. If you're evaluating, we also need to be open to changing how we evaluate implementation. If you're a researcher, be open to changing how you're doing your research. You might decide, I'm going to do thematic analysis and interviews. After the first week, you might realize that's not actually appropriate. So you might need to change what you're doing, adapt, because again, that's how we work with complexity. We have to be open to adapting. It's an iterative, creative process. So that is all I've got for you. That's part 1, 2, and 3 of the Implementing for Impact series. Any questions? These are my contact details. I hope that's been useful. I hope it's transformational, not just a barrage of information. Anything you're not sure of, don't hesitate to get in touch with me. I hope you have a great week. Thanks a lot. Bye.